Colin, if we just give it another couple of minutes just to let people move across, and then we'll start.
So there's just 2 people so far.
Great. Well, I'll pop back in a bit. Thank you.
Okay.
Maybe the breakout rooms weren't so obvious. Wait, were you here before? Was anybody here earlier?
I popped in earlier, about 10 minutes ago. Chris was already logged in, but I haven't heard him say anything.
Do you want to put your slides up so people know which session they're coming to, maybe?
Yep, can do that. Okay, can you see the slides?
I can, yeah, they're great.
Okay. Well, so we can make a start then, perhaps, Colin, because we're already a little bit late because of the previous overrun. So I start by just introducing myself. I'm Rob Dineen. I'm a professor of neuroradiology here at the University of Nottingham, and I'm Deputy Director of the Clinical Academic Training Programme, specifically for medics. If you were in the previous session, you'll have heard quite a lot about the training opportunities available to nurses, midwives, allied health professionals, but this session is specifically for people from a medical background. The co-presenter for this session, Colin Crooks, is going to talk after I've done my presentation, and I'm sure Colin will introduce himself when he starts to present. So in this first part of the session, I'm just going to give you an overview of the formal structured clinical academic training programme as laid out by the NIHR. And it's a scheme that some of you may already be familiar with. In fact, some of you in the call may have already been part of this training pathway. The NIHR integrated academic training pathway for medics and dentists provides training opportunities in research at multiple levels, multiple stages throughout sort of training and clinical practice. So this diagram here just really sort of represents the different stages. On the left, we've got medical school, and obviously during medical school, there are a number of ways that medical students can get early experience of research. For example, undertaking an integrated bachelor's degree, sometimes a master's degree. Some schools offer MD PhD programs where you can actually do a PhD incorporated into your medical training. And obviously some medical students come into medical school with previous research experience, having done a degree or possibly a research degree elsewhere when they enter as graduate entry medical students. The next stage is the foundation program for the medical school graduates, and within that there is an academic provision, the academic foundation program, and I'll tell you a little bit more about that in a few slides time. After the foundation program, when trainees move into specialist training, start to sort of develop their clinical interest, there are also then a number of different schemes available to support academic training. First is the academic clinical fellowship, which provides protected research time over typically a 3-year period during the early specialty training. That then should prepare the trainee to undertake a PhD, and I'll talk a little bit more about that process in just a moment. Following the PhD, the trainee comes back as a clinical lecturer for the last few years of specialty training, and then once they complete their training and achieve the CCT, there are then a number of schemes that operate at a consultant level to allow you to continue to build your research career. So it may be that you move into a faculty position, something like a senior lecturer or an associate professor position. But then there are also a number of competitive funded schemes. So there are a number of fellowship or research professorship schemes available for people working at consultant level. Things such as, for example, may be eligible for a MRC New Investigator Research grant, or there are clinician scientists awards, as well as research professorships. There are also schemes like the NIHR MRC CARP scheme, which really targeted at research active consultants in the NHS who have previously completed a PhD and got research experience, but aren't in a formal university academic position, but want to sort of get back to doing more research and developing their own research careers. And in Nottingham, we have had some success with that scheme. So this is the pathway as it's laid out. It's a very nice, logical progression. But in my experience and in reality, I think it's unusual for people to follow this pathway all the way from the left side to the right side. And in fact, people often use these posts, I think, a lot more flexibly. That might be driven by their own personal circumstance, what's happening in their life, what opportunities are available, where they find themselves working. But it's also, I think, because each clinical specialty delivers its training in a slightly different way. It has exams at different times, the duration of training varies. And because of that, this nice, clear pathway doesn't always fit all specialties. And an example in my own specialty, radiology, we often find that fitting in an academic clinical fellowship, PhD, and the clinical lecturership, all in the space of the relatively short specialty training we have, the 5 years of radiology training, it's very difficult to make it work. But what we find in reality is that there's a bit more flexibility, and this is something Colin, I think, is going to touch on when he talks, is that there are actually different ways to do it. What we find in the academic training program is, following medical school, people often actually go straight into clinical training, and maybe at that stage aren't considering entering into academia, but then come back into academia at a later date. So we have lots of people who don't do the academic foundation program, but then decide they do want to apply for an academic clinical fellowship and successfully compete for one of those posts. We sometimes find people who have done a PhD previously might, after medical school, not go into the academic foundation program or the academic clinical fellowship, but move into a clinical lectureship later on. That's something certainly that we've seen. Sometimes find that people do a PhD at a different time. For example, I've known trainees who, following completion of the foundation program, an opportunity has been presented to them, PhD, and they've decided to do it at that point, which is absolutely fine, if that's what works for them at that time in their career. We sometimes find that trainees do one of these posts. They do an academic foundation post or an academic clinical fellow post, and then leave academia. They realise that it's perhaps not for them. It's not the right thing for them, or the timing isn't right for their career, and they exit the program. I think that's also fine. You know, if an academic career can be quite demanding, it can be challenging at times, and it's not for everyone. So if having completed one of these posts, the realization is actually that it's not something they want to continue, I think that's still a useful outcome. We do also sometimes find people manage to avoid the formal pathway completely. They still end up at some point doing a PhD, and at some point coming back into a more senior academic post. And say particularly the CARP scheme is one that might work well for that. So really the point of this is to show that at every stage there is an offering from the academic training program to support academia, but in reality it's very difficult to make it work as a sort of a conveyor belt going all the way from start to finish. And we understand that that flexibility is required, and that everyone shapes their own career in their own way. So let's just look at a little bit more detail about different posts. So for the early stage, the academic foundation program, we offer a 4-month placement that provides the trainee with hopefully a positive experience of medical research. It's a chance for them to start to sort of see what's involved in being a clinical academic, to start to interact with other clinical academics, with data, to learn some techniques. It's a good opportunity to acquire some transferable research skills and to start to build up a research portfolio. Here in Nottingham, we would provide the placement as a single form block. I think in other areas it may be provided as some over the course of the foundation program. And these are a really good starting point for trainees to then progress through to the next stage, which is academic fellowship. Now, these are posts that typically occur over 3 years during the early part of specialist training, and they provide 25% of ring-fenced academic time. The main purpose of the academic clinical fellowship really is to allow the trainee to spend time developing a competitive PhD student application. You'll remember on the diagram I showed you, the PhD typically comes after the ACF, unless the trainee has a PhD in hand. And the studentship applications are usually to funders like the NIHR, the MRC, Wellcome, and various other funders provide PhD studentship funding. Certainly for the big funders, they are very competitive. I think that was mentioned in the previous session. They do take a lot of time to work up to get all of the different parts of the application looking really strong. So often have to have pilot data, you may have to have some preliminary results to demonstrate proof of principle, you may have to have had PPI engagement, have all your costs worked out and so on, and all of this takes time. So the purpose of the academic fellowship is really to allow the trainee to identify a topic for a PhD studentship and then to do all of the work to support that. The ACF post provides access to expertise, resources, facilities, as well as providing time to actually acquire the data, do preliminary analysis. And it may be appropriate to also try and get some early publications out related to the topic. So, for example, systematic reviews or meta-analyses that support the application. I'm not going to talk in detail about PhD studentship opportunities, but it's just worth saying if you are thinking about doing a PhD, either within one of these, if you're thinking about working up an application for a PhD studentship, either within one of these academic clinical fellowships, or if you're not in one of the ACF posts but are still thinking about applying for a PhD studentship, you really have to start thinking about it early, and you need to speak to people early. You need to get a lot of input as to how to shape that studentship, ideally identifying 1 or 2 key mentors who are going to help you in the process. And certainly I'm very happy to point you in the direction of people who can help with that. We really want to support people who are going for these studentships. We realise it's a lot of work for the student, but to make it worth it, we're happy to put support in to help. And it may be things like offering peer review of applications that people are drafting, potentially providing mock interviews if you've been invited through to the interview stage. So if you are online here and thinking that you are wanting to do a PhD studentship, talk to us earlier about the support that we can provide. And then for those people who already have a PhD and are approaching the end of their specialist training, we offer the clinical lectureship post. These posts provide 50% academic time over the final 2 years of specialist training with a pro rata extension, by which I mean your final 2 years of specialist training become 4 years. Half of that time spent in clinical work and half of that time in research. And this is really a chance for you to establish yourself as an independent researcher, building an external grant portfolio, building up networks, collaborations, and so on. And also possibly working towards some of those more senior fellowships, so things like a new investigator research grant and the other schemes that are relevant when you reach consultant level. Just to mention that the clinical academic training program, which we run here in Nottingham, it provides a lot of support. So obviously we oversee all the recruitment and administration to these posts. We also provide the ongoing monitoring of performance through overseeing the academic ARCP process, which feeds into the clinical ARCP that you have to undergo as part of your clinical training. We also offer a number of bursaries. So at the FP level, there's a £500 bursary to support attendance at conferences, the work. There's also at the ACF and CL level £1,000 per year to support conference attendance. We also offer a £10,000 pump priming grant to the clinical lecturers to help them establish themselves as more independent researchers. We also put on an annual showcase where all of the trainees, all of the levels come together and present their research. It's a really nice event because it allows particularly the more junior clinical academics to see what the senior clinical academics are up to. It's a really good chance for them to see where they will hopefully be in a few years' time. And the screen grab here is just from our meeting, most recent meeting that we had, which was obviously a virtual meeting. These were some of our academic foundation program presentations, and they were, despite being relatively junior researchers, there were some really high quality presentations, some really nice work that people were presenting. So that was really good to see. Okay, so I'm going to finish talking at this point. That's my overview of the formal training pathway. And I'm very happy to take any questions as we go along from the chat, or at the end, maybe after Colin's spoken, we can sort of have a more broad discussion about how it all works. Okay, so I'll hand over to you, Colin.
Thank you very much. We have a minimal audience at the moment. I will continue with the presentation because this is being recorded and will be a useful resource, I think. Let me share my screen. Okay, so I was just going to cover getting started research, but outside of the integrated training that Rob's just outlined for you. So just briefly to introduce who I am. So I'm a gastroenterologist and a BRC training lead. But I'm also a clinical associate professor with the University of Nottingham. And how I got there was through the integrated pathway that Rob's described as an ACF, which allowed me to put together a fellowship, which was my MLC fellowship, which funded me through my research training and allowed me to get a locally funded lecture post, which led to my current appointment. But I wanted to just briefly talk about doing research when you're not in one of the ACF or ACL roles or the fellowships, and getting into research more full time. And obviously, there are lots of opportunities in clinical roles to do research, whether it's doing audits, whether it's recruiting patients to trials or joining in other projects. It's great to take up these ad hoc opportunities, but if you personally want a career doing research, beyond just doing audit, it takes a lot more time and involvement, because you need larger studies, you need more robust studies, and you need more training of your own skills to be able to lead that research when you're developing new novel knowledge. And trying to do that alongside your clinical role is possible, but there are risks to doing that. Research PAs are often less available now than they used to be. There's a risk that joining other people's projects that you need to make sure that you get recognition for that, and that you're not working without authorship. And obviously, you can be doing work when you're uncosted and in time that's unprotected. So although it is possible to continue doing that, there are better ways to do it and more ways to aspire to doing it as well. So the key things that you need when you're doing research is you need time to be able to do it, and preferably protected time that allows you to have a normal life. You need training because you're going to need extra skills outside of your clinical training, and you also need a project and a scientific question to be answering with your research. And this obviously means that to have time, you need to have salary, and that needs to come from somewhere. In your training costs money, so you need to be able to cover fees and also consider your career development longer term. And you need a project which itself is going to have costs involved and governance aspects. Now, obviously, if you've got in the integrated scheme that Rob described, that helps protect your time and your salary so that you can able to focus on developing these other things over time. But doing this in your own time in the short term is possible, but in the longer term is just not sustainable. So you do need to be looking for other things. And this generally involves a lot of negotiation and managing. So there are lots of different possibilities that you can join the existing projects that are funded. There are some of the local funding sources include the NUH charity and various other research charities. There are some more hybrid research and clinical posts that can become available to support you doing that. And there are obviously often lots of industry-funded projects that provide some funding for someone to do and carry out that research. And it is always possible to do things with some self-funding, but it's not recommended and it's not a sustainable approach. Be able to sort out all of this puzzle yourself is probably not going to be possible, and you need to have a potential supervisor, an advocate, or someone in a research position who can be helping you navigate and negotiate these things for you. Thinking more about training, so I'll split this up. So you think about you're going to need training in the specific area of research that you're doing. This could just be some short courses going up to master's levels, but this is to develop the skills you actually need for your research, which can be very specific depending whether you're in a lab or doing trials. If you're looking at doing an academic career long term, then what you need is a PhD, which is the training that shows that you can work at a peer review level for more than 2 years. And that's what people need to build towards, because that's what sets up your track record and your CV for longer term career. But this all takes time. When I look back over my own training, this added 6 extra years to my training, and it meant that I didn't do as much specialist training as some of my peers. So there's a balance to be had, and you have to make a decision at some point as to what you want to be able to achieve. So the challenges of joining an existing project, so that there's somebody who says, oh, we've got this project, we've got some funding, you can come and do this for a year or two. So the caveats are that this doesn't necessarily give you some protected training, because this is going to be mainly focused on delivering a project. You can have less protected time to prepare for a fellowship or a funding application than you might do if you were on one of the integrated schemes. Potentially it's got less prestige than if it's funding you might achieve yourself, which can make a difference longer term in terms of your CV and track record. And it might mean you need to support other commitments and activities. Sometimes the hybrid might mean that you start, it might give you a year of funding, but then you might need to apply for a fellowship. And that's, in one sense, a great opportunity, because it means you've got the platform from which you can then apply for some external fellowship funding. But also sometimes these posts need to be funded from clinical commitments, which is another thing to be able to balance. But it does have benefits. It means that you might need to have less initial commitments, because you're just committing to something very specific. You don't have to spend the time developing without knowing where you're going. It does give you some time to try things out, and Chris, who's on the call, particularly, I was going to talk about the Masters of Research that's possible, where you do the first year. So it's not a Masters of Science where you're just doing the learning and the studying. This is where you actually do research for a year, and it counts towards a Masters. And if you want to continue, that can then develop into a full PhD. So that is one way you can start to try things out. It does have the benefits that the project is pre-developed, so you can start and hit the ground running because it's previously been worked up. And as I said before, it can provide a good, strong platform from which to then apply for another fellowship. So I did just have a couple of examples of people who've done this. This person couldn't be here today, but they funded their PhD through a charity project grant combined with some industry funding. It only covers the project and their salary, so that means that they are funding their own PhD through their own fees. But that's something that they've agreed and decided that they want to do. And it means they also have to cover other industry side projects that are not directly involved in the PhD. So that's another burden on their time. And their advice was that it's key to be involved in discussions with your supervisor early, so that you're aware of what funding could be potential in the area that you're interested in, and to make sure you understand what the plan is for the project before you start. But again, it's about identifying someone who can do that negotiation, pull these things together for you early on, and making sure that they are thinking of you, not just of the project. Chris, I don't know, are you able to talk and share your microphone? Potentially not. Okay, so the other example is just someone I've been involved with who was able to do an MRes for the first year, and then what they're doing, they transferred and they're now in their final year of their PhD. So this is their slide, which they said, which I was hoping they'd be able to talk about. But so they wanted to have a year out from the clinical work, and they wanted to try research. And I think they met their potential supervisor at a networking event and explained what they wanted to do, and they explained the opportunities. So it's again about the importance of being aware of who's around and talking to people. They started on an MRes for a year where they did partly deliver clinical work and partly started on a research project. They were able to convert this to a PhD, which meant that they then had a further 2 years to complete their PhD. But the work they did as the MRes counts towards that. So as I said, they're continuing to do some clinical work which supports the funding for this post, which means that particularly important in surgery and other specialties where there's a skill, it means that you can keep your skills up to date without losing your skills over the PhD time. And it means there's a lot of variety in the job and keeps you in touch with your colleagues. It does make it more difficult in terms of workload and balance, and takes time out from when you could just be focused on doing the research. And obviously the project for this particular post was part of the post, so it wasn't something that they had the freedom to choose, but they got involved. And again, I think this is a theme that everybody's been saying, is that the more in advance you can plan, the better. And there's a lot of things about in benefits in widening your skills beyond just doing your clinical post, and research is one of those that broadens what you can do, and they ended very positively there. So sorry they couldn't share that themselves, but it's just useful to understand that it is perfectly possible to do things differently than just through the integrated pathway, but it has its own challenges and benefits. I included this slide about the carpal ward, but I think Rob's mentioned that already. And so these were just the summary points from speaking to other people, trainees who've been through this way, is that it's talking to other trainees and consultants early, so you know what opportunities, what things are possible. I think they've highlighted is just make sure you really want to do research, so you're not just looking for time out of clinical work, because doing the research itself is hard and challenging, particularly if you're doing it this way, so you have to want to do the research that you're doing. We mentioned before that you might need to start doing a sort of hybrid funding and then need to apply for a fellowship, but that in itself is a good thing in the longer term. And just one final reminder is just remember that you need to be doing your own training, and that you need fees to be paying for things, so you need to know who's going to pay for the PhD and make sure that's not overlooked at an early stage. There are some resources here, but I think these slides will be available along with this recording. So I think that's all I had to say, and we didn't pick anybody up during that time. Was there anything else you wanted to add, Rob, or shall we stop the recording?
No, I think that covers everything very nicely. So yeah, if we stop the recording now, if anyone does end up watching this recording and wants to get in touch, I'm very happy for you to drop me an email and I can try and answer any questions you may have.
Thank you.
Okay.